If you've ever felt like your hormones are running the show, but no one seems to have the full script, you are not alone. Today's episode is for all of you who want to go beyond the basics and really understand what's happening beneath the surface when it comes to hormone health. We're diving deep into the why behind hormone imbalances, how genes, toxins, stress, and even your detox pathways can completely reshape the way your body uses estrogen, progesterone, testosterone, and beyond. We're also exploring how hormones impact far more than your cycle or menopause symptoms. Think immune response, blood sugar, brain health, and even histamine issues. To help us unpack this complex and fascinating terrain, I'm joined by the brilliant Dr. Liz Bartman. She's a naturopathic doctor with over 20 years in the medical field and a decade in functional and naturopathic medicine. She holds a Bachelor of Science in Cellular and Molecular Biology and advanced certifications in herbal medicine, environmental medicine, and nutritional genomics. Dr. Liz is currently the Director of Clinical Sciences at EndoAccess, where she combines in-depth hormone testing with targeted herbal protocols to get to the root of hormone dysfunction. She's also former clinical educator for Precision Analytical, the makers of the Dutch test, and has consulted on thousands of hormone cases globally. She's the perfect guide for today's deep dive into the intricate world of hormones. So, welcome, Dr. Liz. So happy to have you here.
Oh my goodness. Thank you so much, Karen. It's such an honor and pleasure to be here. I'm so excited to dive into the world of hormones and their
Yes.
complexities. There's a lot.
Yes. And so for all of you listeners, Dr. Liz and I actually met like a couple weeks ago just for a consult beforehand where we just thought, well, let's meet online and chat for a bit and discuss what we're going to talk about in today's interview. Well, it was like two complete hormone nerds coming together and we couldn't stop talking. It was like, oh, yeah, you get it. Oh, yeah, yeah. Hey Liz, it was like
Absolutely.
finding the hormone bestie. It was like, oh my gosh, you get it. You're as nerdy about this as I am.
Absolutely. It was so fun.
And you're
Love
just
being able
so
to get to that level.
smart. I know that I'm gonna have you on multiple times because you have an understanding of hormones that I don't find very often with people that I speak with. So yes, very
Thank you
excited
so
to have you here.
much. Wonderful. I'm so excited to be here. Yeah.
Okay, so where to begin? No, I got it. I got it. First, explaining just kind of what happens between the perimenopause versus the menopause and how these hormonal shifts can affect systems that are beyond fertility because we always think when we think of sex hormones, that's what we go to. We think of getting our period, getting pregnant, and then losing the period, and then, oh, we're in menopause. But it's beyond that.
It's so beyond that.
So
Yeah.
beyond that.
But I think, it's important to remember there is that biological imperative, right? To reproduce. And so when you're making your sex hormones, that is one of their primary goals. You have a lot of eggs. You're born with all the eggs you will have, right? You actually have them in your second trimester in your mother's womb when she is in her mother's womb, right? So
Oh,
you
that's so
have you
weird.
all, yeah,
Yep.
you are an egg, right? You are an egg in your mother's ovary when she's in the second trimester of her gestation. So your
Okay.
grandmother is imprinting on you and your genetics. So that's like that kind of epigenetic programming to the
So
max.
cool. Yes.
Yes, that ancestral. And then your mother's imprinting on you. And of course, then you get your own imprinting in that really foundational first 10 years of life. But all that to say, you have all of these eggs, right? You have all of this potential for future baby. And that's as soon as you come of around age 12 to 14 on average for your first menstrual period. That's the whole drive is to get those eggs to a point where you're really finding the ideal follicle, maturing it to its primary oocyte status, right? Primary egg status, and then being able to release that and whether or not it meets sperm determines whether or not you're going to potentially implant and then get pregnant. Now, all of our hormones are kind of working to optimize that development of the egg. Once those eggs start to dwindle, though, we're losing about 1,000 follicles a month. So we just are going through this process of kind of like, I think of it kind of, it's so weird visual, but I think of it like like a little raccoon or something. A little creature is like in the ovary looking at this bag of gold, and it's like, okay, which ones do I want to take today? Which ones do I need to select? What's the garbage? What do I throw out, right? And that's kind of the process happening each month is your ovary is deciding, okay, which eggs are really solid, which are stable, have appropriate chromosomal response, are not damaged by oxidative stress. That's a huge one. And we now
Mm.
know that the greater our oxidative burden, both in utero but also during our lifespan, is going to increase how many follicles just get thrown away, right?
Oh.
Because there's just a lot of damage. The ovary is very wise. Our body is wise. We want to bring maximum potential to up to bat, right? The
And
maximal
what
ideal.
impacts the oxidative stress the most? Like toxins and like
Environment.
environmental. Yeah, okay.
Yeah.
Yeah,
Environment and
yeah.
diet. And
Oh,
stress. I
yeah,
mean, that's a
yeah,
big one,
yeah.
right?
So we can make our eggs shitty,
Yeah.
really, by not eating well, not taking care of ourselves, stress,
Yeah.
toxic overload.
Yeah.
Oh,
And we're
so
losing
could a
more than
woman
that
like,
pathway.
when you do fertility treatments and they like look for the eggs
Yeah.
and they're seeing all these eggs, can they tell which ones are the ones that have more oxidative stress on them?
Well, that's when they do egg retrieval. If you're doing IVF,
Yeah, yeah.
they will, right? Like
Okay.
that's what they're
They can
looking for. They're
see.
looking for the
Okay.
most viable. They're like, yep, these ones are chromosomally stable. These ones, we have to throw these ones away, right? And that's
Mm,
what they're doing. That's why they pump you full of so much just growth hormone and hormonal stimulus to try to maximize how many of those follicles they can retrieve. And then
okay.
they're doing the process of what the ovary would do otherwise. The
Got it.
technician is now looking at the eggs and saying, okay, we've got, X number that we just can't even use. And then of the ones we can use, here's an XX, here's an XY, and they can actually decide what gender you want your baby to be.
Wow.
That
Okay.
way.
Got it. That's interesting.
Um,
Okay.
but yeah, I bring all of that up though because under a normal healthy circumstance, we're losing thousands of follicles a month during our menstrual phases, right? During each
Okay.
menstrual cycle. And depending on the acceleration of that, we're going to begin to dwindle our egg supply. And that's when we start hitting perimenopause, is when those eggs are starting to drop under around the 30,000 mark or less. It's like, okay, we've got fewer and fewer eggs to pull from. We're really getting to a low supply. And that's when your brain is like, the brain is sending out these little peptide hormones. It's sending out signals, FSH and LH, to tell the ovary, kind of knock on the door and say, hey, we're ready to develop that primary follicle. Have you chosen, which one you're going to bring to the forefront for this month? And if the ovary's like, whoa, we're still waiting. We still haven't selected yet. I don't know that we have enough supply this month, right? That's when you get these longer or prolonged cycles and even skipped cycles because the FSH is like, knock, knock, knock. We're ready to go. And the ovary's like, maybe, maybe not. I got to work on it a little longer right now, right? And so there are things like reducing oxidative stress is going to maintain your egg potential longer, right? You're going to get better response for more years, but also making sure you have appropriate mitochondrial health. The ovaries, the testicles, and the heart have the greatest concentration of mitochondria of any tissue in our
Mm,
bodies. And so the mitochondria are where all sex hormones go to begin their journey, right? So we take cholesterol and we convert it into our star kind of start master hormone pregnenolone, and that's in the mitochondria. And so if we don't have optimal mitochondrial health, then our sex hormone synthesis starts to dwindle. And then we don't have the right little workers, right? The right hormone response to start to generate any follicle that might be there to help nourish it and bring it to that maturation process. Um, so mitochondrial function is really important. And then again, just nutritional status. Do you have the right building blocks? And I would throw thyroid in there too. Do you have the right metabolic drivers
mm.
for that hormone response? And so as we go into perimenopause, our age can really be determined like when we start to notice these kind of cycle changes and status. It's when those eggs, when that follicle reserve starts to dwindle and we're working harder to try to get those last remaining follicles out the door and reducing oxidative stress, improving nutritional status, improving mitochondrial health, making sure our blood sugars are balanced, our stress level is, good in a good place. Those all, and our thyroid is, supported, all will help kind of mitigate those kind of transitional changes that are happening as the ovary is going through that perimenopausal, like, what are we doing here? Status.
Right.
The other thing that's fascinating is that, as that FSH signal goes up, Well, the ovary is not the only tissue in the body that responds to that FSH. And the louder it gets, the higher it gets because the ovary isn't quite ready to accept it, right? We get this resistance to FSH. Adipose responds really nicely to FSH. It loves FSH. It's increasing one specific enzyme, CYP19A1, which is aromatase. And it's saying, hey, adipose, our fat tissue, right? Especially around the midsection, hips, buttocks, those like classic, estrogen,
Yes.
estrogen areas.
The belly, as we call
Yeah.
it. Yes.
I mean, really, it's kind of an advantage in a way because our body is saying, hey, the ovaries aren't responding to our knock. We really know we need estrogen. They're not giving it to us. You make aromatase. We're going to knock on your door now. Why don't you kick out a little more estrogen for us? And that's exactly what that adipose tissue does. It says, okay, well, if we have higher aromatase expression, we're going to take androstenedione, this intermediate from DHEA, from pregnenolone, from testosterone, right? This little intermediate. It can go multiple directions. If aromatase is upregulated, it goes into estrogen. So we kind of kick out a little extra estrogen from our fat tissue. And it's not as much as the ovary will ever make, but
Right.
it's something, right? It becomes a buffer. It becomes a little extra to maintain that cell function while those ovaries are like going to be on our decline here. What happens though in perimenopause, right, is that then the ovary's like, oh yeah, we'll open up the door and now we'll really surge estrogen. And now you have it from two places. And now you get like this huge estrogen excess. So
So FSH will, in a sense, signal to the aromatase.
yeah.
If the ovaries aren't listening, then FSH starts to act on adipose tissue, making it so that it increases the rate that estrone, which is the estrogen that we make in our fat tissue, increases. So it'll help to increase that so that that will then make estradiol.
But again, estrone
Fascinating.
not as active, right? It
No.
does become the primary sex hormone for postmenopausal years, and that's why,
Yeah.
because it's the adipose kind of kicking out now that the ovaries are like, we're offline. We're no longer making
Yeah.
it. We don't have any reserve left, right? So they go into a little, just close the factory door, right? And now it's the adipose that really is the primary driver of any residual sex hormone synthesis, unless we're bringing it in through like bioidentical hormone use. Right?
You know what, Dr. Liz? I'll tell you what. I did not know this, but I have said for years that I'm like I think one of the reasons we gain all this weight in perimenopause when we start losing estradiol, and our body is smart and it knows that estradiol is the most important hormone for a woman, and is like, okay, where can we get this from? We can get it from estrone. So let's increase estrone. And that is a more inflammatory estrogen. And the more estrone we have, the more fat we can put on our body. So it's this vicious cycle. But I've always said, and I didn't have any science to back this up. Like I couldn't find any purpose, anything to back it up in the research. So for you to say this to me is so great. It's like,
Yes, I mean,
oh,
it really
okay, now
is.
this truly is what's happening. Like I knew it
Right.
was, but
It is. Yeah. I
I
mean,
didn't know
and you
how.
really have to look at, because like looking at just one keyword driver for like looking at studies, it's like, oh, there's nothing just on this path. What there is, though, is like you look at the Society of Endocrinology, and they defined adipose as its own endocrine gland back in 2010. They were like, hey, it not only stores
Right.
hormone, which it does too, like it also stores hormone, but on top of that, it's actually synthesizing. It has the enzymes present that make it capable of being able to synthesize its own sex hormones. So it is therefore its own endocrine tissue. So it's not like this ancillary tissue. It has purpose, right? Which totally makes
Hmm.
sense.
Hmm.
And then you look at, okay, what are the roles of FSH? Well, what does FSH do? It increases expression of CYP19A1, aromatase. What does adipose have? Aromatase, right? And so you start connecting the dots and you're like, oh, okay, here we go. Here's where that all fits in. And it absolutely is this just because we know women in our peri and post kind of later peri postmenopausal transition and then that postmenopausal just phase of life, we put on more weight. It's more,
Yeah.
it becomes easier, right, to put on weight. And part of that
Yeah.
is because the adipose is becoming more metabolically active, partially to keep up with this hormonal demand.
Yeah. And so many practitioners, I would say majority actually, they won't give a woman estrogen replacement therapy in perimenopause. Like they all are like, no, 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 not till, especially doctors are like, oh, you can't have HRT until you are in menopause. And I always say, if we could catch this earlier, if we can catch the decline of estradiol so that this doesn't happen, so that the body doesn't have to increase aromatase, and then we're not gaining all this weight. We're making women wait sometimes for 5 years or more, suffering immensely because she still has estrogen, so she can't have any HRT. And it's like, well, what if we caught this beforehand and we could save her from gaining 20, 30, 40 pounds and having the metabolic issues that come with losing estrogen?
Absolutely. Yeah. And I think, the hesitancy to adding estrogen is that you do get these surges, but they're
Surges, yeah.
temporary, right? We are not in a vacuum. We are so dynamic. We are changing every day. So even if you get these occasional surges in estrogen, it doesn't mean you're high all the time. If you're struggling with those symptoms, it's finding that balance. It's like, okay, where do we need to be? We don't need to do your postmenopausal dosing of estrogen, but we can definitely get you into a range that's supporting those receptors. So when you decline, you still have an appropriate feedback response that's not saying, oh, go into critical state mode, increase adipose, increase CYP, like 19A1, let's get that aromatase going. It's like, oh, okay, no, we still have that backup. We still have a little there to support. So I absolutely think we delay in conventional medicine, right? They delay
Yeah.
the initiation
And
inappropriately.
estrogen does have a negative feedback loop too. So don't you think that if we put in a low dose to a woman that is in that state of the estrogen roller coaster,
Exactly.
would that not calm the roller coaster?
Gives it a little more of that steady state. Yeah,
Right? Because
absolutely.
the brain's gonna say, oh, there's estrogen. I don't need to have this like massive fluctuation of, and pour out the estrogen.
Right. Yeah, absolutely. And it really is, it's all about the balance, but you have lots of different sex hormones working in tandem and working in synergy. And it is finding that balance, not just of the estrogen, but also of our adrenal function, what's happening with cortisol, what's happening with DHEA, what's happening with testosterone, right? And then of course progesterone as well to just even it out. But I think there is that role to kind of mitigate the severity of those fluctuations by bringing in those hormones a little earlier, checking them out first. Like, so where are they? What are their levels? What are we seeing symptomatically? And then
Hmm, hmm.
how can we support them best? And part of that
So,
is bioidentical. Mhm.
yes. And then, okay, so tell me what's happening then behind the scenes because okay, so we're losing the estrogen. We are gaining weight, possibly. About 80% of women will gain weight when this happens due to the drop of estradiol. But what's happening behind the scenes besides the fact that it's affecting fertility or periods and weight? What else is happening
Oh,
when we're losing these hormones? Like
yes, so much. There's so much
so
going on, and
much.
it's amazing. Yes. I am number one. So I'm going to start with the cortisol piece just because I find it so fascinating. But when
Mhm.
there's that decline in the like those just dips and peaks in estrogen happening in that perimenopausal time frame, and you're getting that increased aromatization, you're getting increased adipose. Well, unfortunately, in that same vein, you often get metabolic syndrome risk going up and blood sugar dysregulation, right? And so metabolic syndrome is that triad of high blood pressure, high blood glucose, and high cholesterol and the weight gain. Cholesterol is not always included, but the weight changes, right? So the
Yeah.
glucose dysregulation, the blood pressure changes, and then the weight with or without the cholesterol element. But then you get, so what else does adipose love to do? It loves to metabolize cortisol. It loves glucose. It loves to stimulate it. So leptin resistance is a big piece of kind of our perimenopausal time frame where we start getting this like, oh, we need this adipose. Adipose makes leptin, tells the brain we're full, so then we don't make as much. We start burning the adipose. Well, we don't want that. So we get into a leptin resistant state. We go into like a cell survival mode. It's almost like a hibernation state where it's like, no, no, brain, don't listen to the leptin. We need that adipose. We need to get a little more. Well, what happens then is you get this glucose dysregulation. It starts saying, oh, okay, so we need to store more sugar now. We need to,
Mhm.
and so what happens there is cortisol starts to increase. Cortisol directly, to try to regulate inflammation. If we have high stress, we're going to drive that up a little more as well. Adipose loves to metabolize cortisol, so now it's going to be pulling cortisol into the tissues to just propagate this vicious cycle of glucose dysregulation, leptin resistance, and weight loss resistance. Ultimately, is what happens there. Well, what else does cortisol do? Cortisol increases CYP3A4. CYP3A4 is a powerhouse enzyme in the liver. It processes around 60% of the medications on the market. So it's not, one that we want to suppress ever.
Yeah.
But when we have elevated glucocorticoids, be it from natural or and exogenous, so like from medications, from like steroid use, but for this example, we'll say, cortisol from the adrenals, high stress. Uh, that's stimulating more of that CYP3A4, which is taking estrogen, and it pushes it into this form called 16-hydroxy-E1. So it's taking that estrone that's already a little more on the inflammatory side and
Yeah.
moves it into a very tissue proliferative intermediate.
Right.
What's really interesting about 16-hydroxy-E1 is that we have estrone and estradiol that are capable of binding to estrogen receptors, right? And they basically, because they're a fat, they can transiently just kind of float right into our cells, but it's in that matrix, in that cellular matrix, that there's these little receptors that they can bind to. They form a complex, and it's that estrogen receptor complex that now goes into the nucleus of the cell and says, hey, we need to increase expression of XYZ, whatever it is for that cell. There's a lot of things it increases, but let's use just endometrial tissue for the example. It's going to increase endometrial proliferation. Or let's use breast tissue. It increases breast tissue proliferation, right? Like it can lead to fibrocystic breast changes, a little breast swelling, some breast tenderness. Well, then it starts to metabolize 16-OH is in the cell. It can also bind to estrogen receptors. So as a metabolite, it also has estrogen affinity, receptor affinity. So it's like you're getting this double hit on a receptor that's increasing the proliferation potential of tissue. Adipose increases proliferation of adipose, increases proliferation again of the breast tissue. Does have benefit to other tissues, like it's going to be a little more bone protective
Hmm.
as an intermediate, not as strong as E2, but a little. So there's a reason our body does this, right? It's saying, hey, we don't have a lot of estrogen. We're going to become a little more cortisol resistant. We're going to start elevating that cortisol response and pulling that into the adipose to further propagate a little more of this like proliferative, potentially protective estrogen intermediate. But it's a yin yang. There's some
Yeah.
negatives to that as well, right? It's not non-discriminate in what it causes to grow. It doesn't cause cancer, but if a tumor is there, it can cause it to grow a little faster. We want to be careful with that intermediate for sure. So it's kind of this interesting cycle when you start to see these estrogens go on these roller coasters and start to, ultimately shift towards a decline. All the things our body does to try to maintain that estrogenicity, right?
And
That
then it did,
potential
and then from
estrogen.
16 it goes to estriol.
Yes. Which is more of our what we would call like the protective estrogen. It's a little more gentle, a little
So
safer,
do
but
you
that
think
gets
do you
readily
figure that's
sulfated.
why that's happening? Because if it's getting poured into the 16-OH, which is acting like estrogen on the receptor, so having the same signaling, and then it can shuffle down and convert down into estriol, which is a very non-proliferative
Mhm.
estrogen.
Yes.
So I got that
We
right?
want to see those together, right? We want to see them both. Like if one is high, they should both be on the higher side because they should be pushing that path. If one's lower, one's higher, that's when we start to see more of that intermediate. Like if 16-OH is taking precedence, okay, now we have a little more of that proliferation versus more of that natural progression and protection. So it is interesting to look at those ratios as well. And they're
Yeah.
they're sulfated, they're not methylated. So they don't go through kind of this phase two conjugation that other estrogen intermediates would go through. They rely heavily on biliary conscious, so biliary health, and then on gut and being able to circulate out with gut conjugation. So things happening with the gut. The
Ah,
estrobolome is actually getting a lot of research recently. And we know
yes.
with the estrobolome, there's benefit to having more active estrobolome activity, but basically it's a collection of bacteria in the gut that make beta glucuronidase. Whenever you hear that term ACE, that means it's an enzyme that cleaves something off. It cuts something off, right? And so glucuronidase is cutting off a glucuronide subchain. So basically, when estrogen gets broken down and pulled out of the body, it has to get this glucuronidated side chain added to it to make it water soluble and conjugate out into urine or stool. Well, when it hits the gut, if you have a lot of these beta glucuronidase bacteria, they have a bunch of scissors that are cutting off all of that side chain and letting estrogen go back into circulation. So it actually gives it a double whammy. Now, in our postmenopausal years, when we don't have a lot of estrogen around, that can be of benefit because, again, it's helping to recirculate and get any additional, like kind of residual activity from what little estrogen we have. But it has to be in balance. Right? If
Mhm.
they're recirculating and it just keeps hitting 16-OH metabolism and keeps getting more and more proliferative in its activity or inflammatory in its response, now we have a problem, right?
Mhm.
And of course, in our younger women who are still cycling, or even in perimenopausal years, when we are going through these huge fluctuations, if we have higher beta glucuronidase, now we're recirculating even more estrogen, kind of adding insult to injury, right? It's like, oh,
Right.
okay.
So
So
is
looking at the gut.
would the calcium D-glucarate then,
Yeah, that's
because
exactly what it does.
so that would help that
Yeah.
situation and that pathway to support it, correct?
It neutralizes the beta glucuronidase essentially. Yeah. So it
Right.
ensures that the estrogen stays inert, right? That it stays in a form that can be eliminated and secreted out of the body. Yeah.
Yeah. Do you think that the toxic overload in the environment then is driving perimenopause to start earlier and earlier now in women?
Yeah,
Is that what's
absolutely.
driving that? Because we're
Yep.
just making us like these eggs, how you were talking about how if they've got a lot of oxidation, like we're is that yeah, that's driving it basically.
It's a big driver.
Yeah.
Yes. And this is one that's not just in the functional medical space. This is being acknowledged in the conventional world. In fact, Medscape. Anytime I see an article coming up in Medscape, I'm like, okay, MDs are on this now too. They
Yeah.
realize the issues. But they were talking about the impact specifically of micro and nanoplastics on our overall health and how this is kind of where it's in the environment at this point, right? There's no way to
Yep.
eliminate it, but we can reduce any future use of it. And its impact on health, they're saying, is multi-billion-dollar insult to healthcare
Oh,
because of how much it's impacting what they're seeing, right? In terms of cardiovascular risk factors. They're finding micro and nanoplastics in plaques, specifically unstable
yeah.
plaques, right? And so these are going to be the ones
Right.
that go to the brain and the heart and cause strokes and heart attacks. And they're definitely finding it. They have found it in every single tissue in the body at this point, nanoplastics, but it's in highest concentrations in tissues like the heart, the brain, and the ovaries and testicles in men. And they are associating it with reduced fertility outcomes, and even risk for those premature ovarian insufficiency, which would be, going into menopause before the age of 40. And so there's some
Yeah.
profound impact for sure.
It there really is. And I think too, there's a lot of research showing too that it is driving up uh gender confusion, I guess I would call it. I don't know what the politically correct way of saying that is. But it is that like we're hearing that it's causing, alligators and crocodiles or whatever to have both sex, like be born both male and female.
Yeah.
And so they're just saying like, yes, this is happening now in humans.
Yeah.
Yeah.
I think, yeah, they definitely. So the issue with plastics, our bodies, macroplastics we can get rid of because you can bind it
Mhm.
and kind of poop it out. But these micro nanoplastics, our body can't easily get rid of them, right? And they are hormone modulating. They bind to hormone receptors, which is the scary part. So they can bind and reduce the efficacy of our actual hormones from being able to bind and have the positive influence, right? They're just
Mhm.
blocking that receptor from being able to bind any hormone. They can also cause, especially in adipose, right? We have a lot of plastics and other like or no, parabens, phthalates. Those are going to be kind of our obesogens, toxins that can increase kind of the proliferative response of that adipose. So again, we go back to the adipose, and it's like, well, here we have all of these, plastics in the environment and other chemicals that are really triggering cellular response to proliferate adipose because it's where we can store those toxins. We don't know how else to get rid of them. Let's store them in a very relatively safe tissue, adipose, and then
Right.
that makes it
Yeah.
harder and harder to lose the adipose
The
as well.
obesogens.
The obesogens, yep.
Yes.
They
I've always,
are.
and I think that that's what's driving the epidemic of weight loss resistance in women.
Absolutely.
It's this. Yes.
Because these obesogens, and especially the nano and micro, they're everywhere. These plastics are everywhere.
Yeah,
They are
yeah.
in, anything that's any beverage or food that you consume that isn't leaking all over the place. Like if you're not making it yourself in your home, right? And you get something to go or you get something in a container of some sort. If it is not leaking everywhere within 10 minutes, there is a nanoplastic lining, polymer lining that container, right? Like that's the
Okay.
only reason you're not getting fluid, out. Because if it was truly just paper, it would be leaking out. Paper is porous, right? Like
Yeah.
food droppings drip out of it, and beverages would drip out of it. So if it's not, like that's what I always just think about it in the easiest way. You're not getting
Oh,
hormones
it's
for
so
yourself, so that's
scary.
that part.
And xenoestrogens
Yeah.
are strong, like our hormone receptors will prefer the xenoestrogen over our own because it's stronger,
It's a much more potent affinity.
potent.
Yeah.
Okay.
Mhm.
So it'll pull that in before, and we do not want that.
No, no,
No.
because those are not going to be triggering the same cascade within the nucleus, right? So when you think about what's happening as a hormone, as a sex hormone is binding to an intracellular receptor to form its own little complex, its own little like unique formation, right? So you get like this estrogen bound to the receptor. That's what's actually going into the nucleus to target DNA expression and tell it, hey, program it to do something different, right?
Mhm.
That's what all of our sex hormones do. It's program a cell, right? And so if you have a xenoestrogen instead, a xenoestrogen estrogen receptor complex, not going to do the same thing to our DNA. That's an oxidative stressor right there. That's now kicking up NF-kappa beta, which is a very pro-inflammatory driver within the cell to kick up all sorts of dysregulated immune activity. And that's not optimal for good health. I'll say that. Yeah. Versus estrogen, estrogen is going to be increasing expression of PEMT in the liver. That's our natural de novo. So in our body's ability to make choline. Choline is critical for bile synthesis. So when estrogens are present, they're helping with our own production of choline. If estrogen is not present, if it's too high or too low, that's when we start to get biliary stagnation. And that's why one of the risk factors for gallstones is being female, like they call it the five F's, right? The female, fair, fat, 40, or fertile.
Right. Yes, I've heard this.
Because having either too little or too much estrogen, so like during pregnancy, women are at a very high risk for gallstones, and during our menopausal years, very high risk for gallstones. Because we're not making as much choline, we now become dependent on it in our diet. And if we're not eating choline rich foods or we're getting adulterated forms of choline, they're not going to be utilized in the same way. But
So that's from too much or too little estrogen being made.
yeah, yeah,
Then we have effects on the choline production.
on choline synthesis. Yeah.
Okay.
So we
Okay.
can make
And
our own
then,
choline, but we have to have
yeah.
estrogen to do it. Yeah.
Oh, okay.
And so
So
our
in,
xenoestrogens are going to block that cascade. And that's where we actually get increased risk for fatty liver. We get,
I was
so
going to say that.
it's,
Yes. So
mhm.
because I've heard that the drop of estradiol, one of the things that will
Yeah,
happen in menopause is you have a higher risk of fatty liver.
yeah, absolutely.
Okay. Yeah. Yeah. All makes
That
sense.
choline piece, choline, taurine, right? Estrogens are critical for nitric oxide expression.
Yes.
So that's our
Yes.
vasodilation. That's an antioxidant actually in our brain as well. And so when you
Yeah.
get this decline, or you get blocked receptors because of xenoestrogens binding and not allowing estrogen to bind, we're reducing our nitric oxide synthesis, right? And so we get higher risk for high blood pressure. We get, right? And so lower
Lowered libido.
perfusion. Yeah.
I had Susan Bratton on here and she was like, yes, hormones affect your sex drive, but the lowered nitric oxide is going to affect it. And she's like, we need estrogen to make nitric oxide.
Exactly. They work in tandem. And
Blood
again,
flow
we
to the
think like,
vagina.
yep. And for men to the penis,
And
right? Like
yes.
for
Yeah.
both. And I think it gets more press, right? That's what Viagra is doing,
Yeah.
essentially, is increasing nitric oxide. Women don't have that medication, supporting them, but estrogen is a natural kind of like Viagra in a way for women,
Yeah.
just estrogen.
Well, and how many women I've talked to that will say, well, testosterone replacement didn't increase my libido, but estrogen did.
Absolutely. And that's the other misnomer, right? We think, oh, well, testosterone improves libido in men. It should in women as well. But they're very different hormones in different bodies, right? Like women, we don't have a lot of androgen receptors. We do have them. Testosterone is important for sure. But
Mhm.
look at values, right? Like for a male to be hypogonadal, for him to be diagnosed in the medical literature, right? We know functionally this is a very low number, but just like conventional diagnosis of not making enough testosterone in a man is making under 300 nanograms per deciliter, right? Like 300. Women, if we're making maybe 20 to 30 nanograms of testosterone in our peak, like maybe we'll get up to 40. That's really good,
Yeah, yeah.
right? Like that's a tenfold difference, right? So 10
Yes.
times. So like a man at his lowest is making 10 times more than a woman at a pretty good level of
At a peak.
testosterone. Right.
Yeah.
And so you have to just think, okay, well, what are the receptors then? If we're only making that little, we don't have a lot of receptor response to the testosterone. It's not doing the same thing in our bodies as it's doing for a man, right? So don't
Right.
expect to have the same outcomes.
Yeah.
Versus
Yeah.
like estrogen, men don't make a lot of estrogen. They should make about, of that testosterone, they should make about 2% conversion in a healthy optimal state,
Mhm.
2 to 7, should convert over to estrogen. Whereas women, we're going to make in our peak a lot more estrogen just to help trigger follicular rupture, to help trigger that follicular maturation and that just the development of our womb, right? The endometrial response. And so, but what happens, and this is what I always joke with my postmenopausal women, right? So in our like peak levels of estradiol, right, for women should be around, like in our luteal phase, around 100, 150, 160 picograms per deciliter. And this is all US measurements. So I know, I
Yep.
think,
No, I'm all US. I
yeah.
always have to convert to Canadian because I don't know
Yeah.
the.
Which is really what the rest of the world uses. So I'm always like, oh, yeah, I have to make sure
Yeah.
I'm not, because we're using very different. Yeah. I'm not the standard international for whatever reason. I don't know why. But we want to do our own. But okay, so if we're like, 100, 160, kind of is the range. Now, women at ovulation, you're going to go into the 200, 300 range even, right? Men are always going to hover around 50 for their estradiol. But here's the kicker. Women in our menopausal years, once we hit that postmenopausal transition and the ovaries are no longer synthesizing estrogen, we go from this like beautiful 100, average down to 50 if we're lucky. 20 is usually where we land,
Yes.
right? Like, or
Yeah.
less.
Or less, where it's just like, you just don't have any. It's saying like
Yeah,
you've got less than five.
yeah, exactly. Like super low.
Yeah.
Whereas men, even though estrogen's not a primary driver for them, as long as they're synthesizing testosterone, they will
They
always
will
be
make
in the
it.
50s, like 20 to 50 range, because they're always converting around 2 to 7% testosterone, sometimes more if they're aromatase. And this is where andropause, right, is an issue for men, because aromatase does go up for them as well, converting more testosterone into estrogen. And again, they don't have as many estrogen receptors as we do. So estrogen behaves differently for them. But I always joke with my postmenopausal women, I'm like, I just want to get your estrogen to the same range as a man of your same age.
Yeah. Yes, isn't that the truth? Hey, never thought about it like that. But we're not going to get your testosterone to the same.
But we don't need to do testosterone. Yeah, yeah, because
Yeah.
it's really the estrogen for women that's helping the libido because of the nitric oxide
Yeah.
response, because of the dopamine and serotonin response that it has in the brain, right? There's
Hmm.
the nucleus accumbens in the brain that really is regulating dopamine response primarily. But it shrinks by up to 20 to 30%, depending on the article you read. But it shrinks a significant amount in our postmenopausal years. We're losing those dopamine receptors, and that's our pleasure and reward center.
Oh,
And estrogen's a driver for that. Testosterone helps a little with dopamine, but not in the same way it does men. Women need
right.
the estrogen piece. The other thing estrogen is doing is it helps with tryptophan hydroxylase response. So it's converting tryptophan into 5-HTP, which can become serotonin.
Or
It also is
melatonin.
supporting, yeah, and melatonin downstream.
Yeah.
Absolutely.
'Cause that's how estrogen, I'll tell women, yes, progesterone you want for sleep. However, sometimes it's the estrogen that you need to get up because it's going to help make serotonin, which will help you sleep, as well as melatonin.
Yeah.
Way downstream, kind of,
Yeah,
right?
exactly.
Yeah.
But it's supporting. Yeah.
Yeah.
As long as it goes that direction. Well, here's the other
Right.
issue. When estrogen drops, the risk is that tryptophan doesn't go to serotonin as much. Now it's going over to kynurenolic acid, which is pro-inflammatory. It does have a little buffer. It can help with NMDA expression. So it does help a little with neuroplasticity. But as soon as you start converting kynurenine into quinolinic acid, that's a very neurotoxic intermediate.
Why
And
does it do that?
so
Okay.
because you're dropping not just so it's this enzyme called IDO. And it's that conversion of tryptophan to kynurenine. And we want that modulated. We want more estrogen supports conversion of tryptophan more to serotonin through the 5-HTP response
Okay.
through the tryptophan hydroxylase synthase. But if you have IDO upregulated because you don't have enough estrogen to modulate it, now it's pushing more into kynurenine.
Okay. So estrogen modulates that. And so once it
Yes.
drops, then it kind of gets out of control.
So it's like like a little fork in the road, and it can go one direction or the other, and estrogen kind of dictates where that tryptophan is going to go. And yeah, inflammation is going to drive more into kynurenine as well. So if you're already inflamed and now you've just lost estrogen, I always say our perimenopausal years are a time when underlying imbalance that we had buffered because we had enough estrogen are suddenly revealed, right? And so if you're already kind of in a pro-inflamed state and pushing more into kynurenine anyway, and now you lose that estrogen, you've lost your buffer. Now you're going to feel really neurotoxic. You're going to have more agitation, insomnia, brain fog, right? So it's kind
So
of
that's
these,
what
and
could be driving brain fog is
mhm, oh,
that.
absolutely. Well, and then estrogen
Oh,
plays a role with BDNF expression. That
yes.
can
Yes.
be
That's what
really
I know more on that end of things. So I
yeah,
didn't, yeah, okay.
so many
Yeah.
pieces.
I know. It's so fascinating to me. I just like, oh, I just soak this up, this stuff. It's so
And
fascinating.
yeah, and progesterone very important as well. It's
Yes.
helping with that GABA modulation. So it's not improving GABA production, but it's improving how well it can enter into GABA receptors. So it's kind of like
Mm.
a valve is turned on to allow it to flow into our neurons, right? So if you have plenty of GABA and you've now turned open, that valve is now open because progesterone's there. Now you're getting that influx of GABA and you get the neuro calming response. That said, it can be really sedating for some women, like just knocks them out. They don't feel good at all, right? Because they're just too
Yeah.
tired. But it's also that receptor, that channel is non-discriminant. It's going to accept glutamic acid as well. So it's not just GABA. And glutamic acid is kind of the intermediate right before it becomes GABA. If you turn up like the volume to let or turn up the valve to let in more of this
Hmm.
GABA or glutamic acid, but you don't make a lot of GABA, you make a lot of glutamic acid. Now you're going to get more neuroexcitatory, and that's called that paradoxical response to progesterone that some women have, where it just makes them really anxious and agitated and moody because they
Because
really need
so,
more because
okay.
progesterone's not helping GABA, it's helping GABA enter the neuron. And
I
so
see two different things happening with progesterone sensitivity. So I'm wondering if it's this, if it's both from glutamic acid increase, which so some women like myself, if I take too much oral progesterone, I get extremely weepy. Like I can't stop crying. I'm severely depressed. Everything's dark and gloomy and very sedative. And then I have women that go the opposite and they get agitated, they fly off the handle, they get super angry, and they're like, oh my gosh, I got to stay away from progesterone.
yeah, I think,
Both
your
glutamic?
response, I don't think so. I think your response is more like you're just very progesterone sensitive, right? Because
Hmm.
progesterone makes it just mellows things out. And if it's mellowing it too much and you don't have enough dopamine to counter that and enough serotonin to counter that to be a little more on the happy neuro, responsive side, more stimulated, more focused side, then that GABA response is really going to sedate and like just make
Hmm.
more lethargic and mood will just kind of be more in that like mellowed, potentially even more depressed state.
Hmm.
Again, it would be with if it was out of balance with serotonin, I'd say you probably need more of the serotonin dopamine balance to even
Yes.
it out, right? Whereas like the really agitated, I'd say it's either that paradoxical kind of more glutamic acid response. It can also be, so the other thing progesterone does in the brain, and this is where it's like when we think about PMS and PMDD, it's
Yeah.
really more a brain response than it is a hormone response, right? Like researchers have been looking at what is the hormonal connection here? Is it too much progesterone? Is it too little progesterone? Is it too much estrogen? Is it too little estrogen? And really what they find is, well, yes, to all of it. Like,
Yeah.
could be any of it. Could
Yeah.
be
Yeah.
totally normal hormones, and yet they still have PMS. What's happening? And so it's like, oh, well, let's look at the brain. And so they do these functional MRIs, SPECT scans, looking at, so two very different types of imaging, but both have been used to look at like metabolic response in the brain and what lights up at certain times during the cycle. And it's the cerebellum that tends to light up during the luteal phase of the menstrual cycle, which makes sense. This is where we really need to be focused. We're looking at like maintaining safety, protection, right? Like we want to make sure that we're regulating ourselves in case we got pregnant so that
Right.
we can be safe and we can maintain that pregnancy and have a healthy baby, right? Like, so it makes sense that the cerebellar response starts to increase in its metabolic demands with progesterone specifically elevating in the luteal phase. Now, as long as the cerebellum can take in glucose and has appropriate metabolic or mitochondrial response and metabolic activity, those women don't seem to have the PMS symptoms. They're regulating correctly to the progesterone increasing metabolic response to the cerebellum. But progesterone, right? So if progesterone increases that metabolic response, if glucose can enter and is being utilized correctly, they don't have symptoms. When glucose is not being utilized correctly, or mitochondria is not able to utilize and create that ATP response from that glucose, from that
Hmm.
energy that it needs, that's when they start to see PMS develop. It's underactive cerebellar response to that higher pregnenolone or higher progesterone and higher kind of glucose demand that's happening in the brain during the luteal phase of the cycle. And then what can happen is you almost get this like coup contra coup like response where the prefrontal cortex and the anterior cingulate tend to get overactive in PMS. And those are all like where we have our rational thinking and think through like what does this thought
That's why we
mean and
become
how can we
irrational.
use that, right? Well, like just kind of thinks through all those things. And then the anterior cingulate is like the fear, right? It's like being able to shift through fear and shift through anxiety and get through those emotional turbulence, that we're experiencing day by day. Well, when they get hyper focused, you can't do that. It's like, I'm just going to get fixated on these thoughts and this anxiety, and it spirals. And it really is. It's this kind of progesterone induced increased metabolic activity in the brain that's not getting met by the mitochondria and by that glucose response in the brain, in the cerebellum specifically. And so, like when you start thinking about progesterone response in the brain and like the depression piece and the lethargy, it's like, well, or even the anxiety piece or the
Hmm.
agitation,
Hmm.
could it be the more glutamic acid response? Possibly.
Hmm.
Or could it also, in tandem or just on its own, be poor metabolic response in the brain to that higher progesterone? Like it's increasing the metabolic demand. Are we meeting it? Can we maintain it? Or is it creating this kind of like opportunistic hyper frontal response?
Yeah. And I've heard too, like there's a like somebody's calling it neurosteroid sensitivity, which is what I've always called it too, because I read this woman's report on that on PMDD, just saying that some women, it's not so much that they have too much GABA or progesterone,
Right.
neither one. It's that they have this like paradoxical reaction that on these GABA receptors, it's neurosteroid sensitivity to it.
Yeah, just more of that, yeah, kind of add like
Glut the
opposite
t
response of what we would normally expect. Yeah,
which would
from
be the
that
glutamic acid increase,
would be more like a
probably,
glutamic or a metabolic response. Yeah.
or a metabolic response. So what's the
Yeah.
solution to this? Like
Yeah.
working, because this talk about going upstream, which I think is so important. We never do that. We don't do it enough, which is like, let's follow this all the way up and go, okay, what's happening on the brain level? And if
Yeah.
it's a mitochondrial issue, do we then focus on improving mitochondria, which I know is vast, like,
Possibly. Yeah.
but there are supplements that you could take to improve mitochondrial function.
Well, and
Would
one
that
that's getting a
help?
lot of press right now is oxaloacetate, and it is kind of like in this branded patented form that's only a few companies are making right now, and because it's like all from the same source, and he's, I think, like in the process of, I don't know what he's doing with it, but it's very
What's it called?
regulated. It's called oxaloacetate. It's actually an intermediate of the Krebs cycle.
Oh,
And you have to have it in a specific form for it to absorb well, because as you would expect with most things that are made at an intracellular level, if you take it orally, you're probably going to break it down really fast, right? You want to get it actually into the intracellular space for it to work. And so there's this form of oxaloacetate that's like in this lipid matrix that allows for better absorption, but it is getting clinically studied right now to improve the metabolic response in the brain to that kind of increased progesterone glucose demand that's happening. So for PMS specifically, not
have you
PMDD.
used it on people?
Yeah, and there's been some great
And
clinical success. It's hit or miss. It works really well for those it's going to work well for, right?
okay, yeah, yeah, because really PMDD, like you said right at the beginning, I've had women that it if they increase their progesterone or take progesterone, it gets rid of it. And then I have women that exacerbates it. And so it would be the same with this, where it's like, if this is the root cause, it's going to help.
Exactly. Like if this is the driver, it does absolutely help.
Yeah.
Yeah. Versus, I do find reducing inflammation, balancing blood sugars, and supporting the mitochondria, just like more globally, kind of hits on all the targets and does improve over time as well. I usually see within a few cycles, women start getting reduced PMS symptoms when we just start to treat more nootropic response, more of the brain's response, right, to these hormones.
Hmm.
So reducing
Hmm.
the inflammation, supporting, it's one of the reasons I love Vitex for the right people because it is a nootropic at its heart, right? It does support luteinizing hormone response, which is helping with ovulation and appropriate cycle like regulation. It does help dampen estrogen as well a little. So if there's an estrogen excess, kind of like low progesterone, high estrogen picture, it's a beautiful herb for that. But it's also a nootropic. It's also working on kind of that GABA synergy and on reducing inflammation in the brain. But also, herbs like boswellia, just a natural anti-inflammatory, regulating glucose. You can do that with cinnamon. You can do that depending on the patient, chromium. There's like so many options
Hmm.
out there. And then just regulating neurosteroid response. Vitamin B6 is a really important one for pretty much all of our neurotransmitters and their appropriate response to receptors in the brain.
Yeah.
I'm a big fan of P5P, the active form of B6. But,
Yes.
anyway,
Yeah.
we go.
The everybody thinks, when they've got PMS of any sort, it's an estrogen thing. It's immediately,
It's not.
always,
Yes,
oh, it's
always.
estrogen,
Yeah.
you're estrogen dominant.
Yeah.
And all the supplements are geared towards let's get rid of your estrogen, let's detox your estrogen.
Which could
Oh
actually be one
my,
of the worst things you could do for someone
right?
in some cases. Yeah. Yeah.
Yeah.
Well, and I do see, like when we talk about the progesterone response again, there's with PMDD specifically, they're noting that higher levels of allopregnanolone, which is that intermediate to the alpha pregnanediol, it's the form of progesterone that can cross the blood-brain barrier and is opening up that GABA channel. That can definitely higher levels are associated with PMDD. So, looking at
Hmm.
metabolite profiles and
Hmm.
seeing high alpha pregnanediol, that can be an indication if they struggle with PMDD that you may actually have kind of more of that paradoxical kind of resistance response in the brain, neurosteroidal kind of resistance or abnormal pattern. But again, inflammation increases alpha reductase, the 5 alpha reductase path for both androgens and progesterone.
Yeah.
So reducing inflammation, supporting the glucose response in the brain, more reason why, that abnormal glucose response may be increasing those symptoms, those neuro kind of excitatory responses. Um, but also giving 5 alpha inhibitors, gentle ones. And one of my favorites is reishi. Reishi mushroom is a 5
Yeah.
alpha reductase inhibitor, but it's like very calming. It's a very
Yeah.
just brain focused, GABA supportive, adrenal
I
supportive,
always
right?
forget
It's a
about that.
really,
And I know it. I
yeah.
know this, but I always go to the saw palmetto route, because it's more popular. And I just think, yeah, that'll
It is
block
more
the 5
popular. It's
alpha.
definitely prostate focused, right? It's more systemic.
Yes.
It's more
Yes.
liver, whereas reishi is
Yeah.
very more neuro
Ah,
responsive.
I'm going
So
to
on
start
that
using more of
progesterone.
that. Yeah.
I love it.
Yes.
But and then
Yes.
actually, kind of coming full circle, we think about the role that histamine has in the brain as well for
Yeah,
some of
that
these
was where I
like
was going to go next.
neuroexcitatory.
Yeah.
Yeah.
But just first, a question for
Yeah.
you. On the Dutch test, they
Mhm.
measure the 5 alpha reductase,
They do. Hmm.
right? Do you see that women that lean they're more to the other to that side, right? So everybody that's listening, if you've never done a Dutch, they'll have the 5 beta and the 5 alpha on this little graph, and then it'll tell you kind of which you lean towards. Are you leaning more towards the beta side? Or are you leaning more towards the alpha side? And then that, like she just said, that is the same enzyme that's converting that allopregnanolone, correct, into the alpha progesterone pathway
So allopregnanolone is just an intermediate to that end product of
to the
alpha
end
pregnanediol. Hmm.
alpha pregnanediol. Yes, so it's going to be pushing more towards the alpha, just like it is pushing your testosterone into dihydrotestosterone. So that's the piece there. I miss saying that. So if you lean more on that 5 alpha, do we then see that those women will tend to have more reaction to that metabolite and have more of a negative reaction to progesterone?
I definitely have tracked it with reports of PMS and PMDD, and it is correlated for sure when you
Okay.
have higher. And we
I have
actually,
found
yeah.
that too. Yeah.
call that out quite often. Yep. And it doesn't
Yeah.
always match. Like you can have higher alpha pregnanediol and not have higher alpha DHT, right? And again, it's liver versus brain kind of response in a
Mm.
way. That's how I
Yeah.
think about that. It's like, are we doing more, like, is it more neurochemical in the activity or is it systemic? Is it really like a systemic inflammation that's just increasing all metabolites to push through alpha, which
Right.
that can happen too. And I
Yeah.
don't see that one correlate as strongly to the PMS as I do just alpha pregnanediol being high and
Hmm.
normal response on the androgens and their
Hmm.
metabolites.
And
So
just so
kind of
everybody
interesting, but oh
hears this
yeah.
too, the oral progesterone, when we take oral, you are converting the majority of that into progesterone metabolites. And so this is why we see that oral progesterone is more women will react to oral progesterone than they will transdermal or vaginal suppository progesterone. Because through those two through delivery forms, we're not going to increase the metabolites as much as we would if we were swallowing the progesterone.
Yeah. Yeah, because by swallowing it, it hits the gut first, right? And it breaks up into all those metabolites. You only absorb about 20% of the progesterone into your tissues from that oral route, which is why doses are so much higher than they often are in a topical or a vaginal form. But all of that progesterone is getting metabolized, and you get those end products depending on what the liver activity is doing, what the gut is doing, right? You're going to see more of that conjugate that can push more allopregnenolone. For
Mhm.
sure. And our body keeps a pretty tight regulation on that intermediate. We want it. It's important for GABA response,
Mhm.
but we don't want a lot of it, right? And so if we're
Mhm.
suddenly kicking out a ton, that's absolutely where you can get more of the kind of adverse side effect profile of that oral
Mhm.
progesterone for sure.
Yeah. Yeah. Okay. Estrogen now and histamine and glutamate.
Mm. Yeah. So estrogens, it's a really fascinating relationship with estrogen,
Mhm.
progesterone, and histamine. When estrogens are high, one of the roles that histamine plays is it helps with vasodilation and it helps with implantation early on. So it's like this trigger and response that we need for that kind of like adhesion and burrowing of a potential follicle if we were trying to get pregnant, right? So again, it hails back to reproduction and this estrogen response. But because we need that histamine in a mild form, in a low form, estrogen actually decreases diamine oxidase, which is the extracellular enzyme that breaks down histamine. So when estrogens are higher, it allows histamine to circulate more freely to get to the right tissue so that we have it available for implantation if that were to happen and to help support ovulation. Once we ovulate, we form this little transient sac called the corpus luteum. That's where all our progesterone is made. Well, progesterone helps stabilize mast cells. So it's like yin and yang. We do need that progesterone around because it's going to make sure that now that we have this surge in, circulating histamine, well, now the cells that are releasing histamine are more stable. Now we only release it when we need it, and now it's going to have a little more ability to kick back up intracellular and extracellular kind of clearance, and then kick it out by the end of the cycle, right? But we need it kind of in balance. Now, for people who are histamine sensitive or don't maybe have enough progesterone to stabilize their mast cells, that's when we can start to see this histamine intolerance as well, which is very histamine. We have to remember it's not just an allergen. Histamine
Yeah.
plays so many roles in the body. So again, it increases nitric oxide or it increases
Yeah, it's
vasodilation because it's
demonized
nitric
usually.
oxide.
And it's like,
Mhm.
no, we need this.
It actually has a lot of roles. It helps with gastric motility. So when like if you're taking seasonal allergy, like histamine blockers specifically, your gut motility goes down a little. You might notice you get more bloat,
Mm.
right? Because it's triggering kind of that gastric response. It is important for stomach acid. One of like Zantac, right? Zantac, they took it off the market. Thank goodness. But it was a histamine H2 blocker in the gut because if you had too much histamine, you'd get acid reflux, right? Was the idea. So block it. Turns
Right.
out it actually increases risk of gastric cancer when you block it. So we know we need histamine. So again, it's like these things we
Yep.
learn, right? But one of it, right? So gastric motility, stomach acid, vasodilation, and in the brain, it is the first cue in the hypothalamus to say, "Hey, it's time to wake up." So it is part of our circadian response. So even before
Ah,
cortisol goes up, it's histamine that triggers the initial ignite of that ACTH response. That's then the knock on the
okay.
adrenals that say, "Let's make cortisol."
Is there a T3 and histamine connection at all? Because I know that T3 also
Yes.
comes up first and triggers cortisol that could come up.
So I absolutely think there probably is. I don't know the
Yeah.
exact connection.
Okay.
Yeah,
Okay. Well,
I've
we'll
got,
have to look that up, Liz.
yes, I know. I'm like, oh yeah, that's probably another part of that. Absolutely. Yeah, but histamine, it really, and this is why taking Benadryl makes you groggy, because it's blocking that cortisol response, right? It's kind of like just
Ah,
sedating it, that histamine activity in the brain. We know that people who don't make enough histamine tend towards more of like this depressive state, whereas people who over produce histamines tend to be more in like this almost manic kind of tendency, and just neurochemically. I know, because it is a neurotransmitter. Anyway, so fascinating role. So if you're, with PMS, if you're, that could be a piece with the estrogen dominance that would exacerbate PMS is like, oh, okay, now we're actually more histamine sensitive. Now we have all this estrogen that's actually blocking our ability to break down any of that excess histamine. And now we're getting that more like neuroexcitatory response in the brain. That could also worsen like the anxiety piece and insomnia that can be
mhm.
associated with early, like right before your next menstrual cycle. I guess late luteal, but right before your period
So
starts.
too much estrogen and not enough progesterone will make us so that if we're not breaking down the histamine and it's going too high.
Right.
Is this correct? Okay.
Yes,
Yeah.
yes, yeah,
I just want to, okay,
yeah.
clarify. Okay. But then if we don't have enough estrogen, it's going to affect the histamine.
We don't have enough histamine response, right? And now we get
We
more
don't have,
fatigue, we get more brain fog, we get more
okay.
sedation, we're more lethargic.
Yeah. Yeah.
Yeah.
It's all about the balance, isn't it?
Yes, it
Not too
is.
much, not too little.
It's a Goldilocks Goldilocks phenomenon for sure.
So if a woman uses too much estrogen HRT, could that then increase her histamine problems?
It can. Yeah, you want to be careful there, especially if you
Yeah.
have a patient who's like got MCAS, which is mast cell activation syndrome, kind of like the hypersensitivity to the
How would
histamine
you address
release.
that then? Like, would you hit it from the histamine angle, but also just from like making sure that person's getting enough progesterone too?
It's all, yeah, you definitely want the balance with the progesterone piece. But it's also, MCAS especially. So histamine sensitivity, mast cells are the cell that carry around the histamines, right? And so they're regulated heavily by the gut. And usually it's if someone's more estrogen
Looking at the
sensitive, we
gut.
know we want to get them up a little more because we know it's so good for their brain, for their bones, right? Like we know that but they just can't tolerate it, right? Any increase and they start getting kind of random itchies and headaches and like like their insomnia increases and they're just like, oh, totally a histamine piece, right? Maybe they get more
Hmm.
diarrhea, more loose stool. That can be another sensitivity picture, or more bloat, because they're just stimulating, right? More gastric response. That's when you think, okay, maybe we need to work more on the gut. Maybe there's something going on with a dysbiosis or just a digestive kind of either digestive enzyme deficiency. Something needs to help work on why their mast cells are being overactive, right? Like, why are they stimulating that response so much that then the estrogen just kicks it into higher gear? Because really, with most bioidentical estrogen replacement, you're not going to get to the ovulatory doses, or
Right.
even for some women, what, mid-luteal levels of estrogen. You're not going necessarily that high. So they shouldn't have too much of a, histamine response unless they're hypersensitive because of usually like an MCAS
Yeah.
to histamine
Yeah.
sensitivity, or they're poor methylators. Like the other aspect of histamine breakdown, so you have extracellular and intracellular histamine metabolism. Extracellular is diamine oxidase, which is an enzyme produced mainly by the kidneys. So making sure kidney health is really good is another piece. But intracellular breakdown is the N-methylhistamine transferase enzyme. And so that's methyl based, right? And so making sure that they have appropriate methyl response can
Mm.
also be a factor in their breakdown and metabolism of effective histamine, like, yeah,
Yeah.
breakdown.
Which is also these is one of the driving factors behind menstrual migraines is the histamine
Absolutely.
component. Hey, yeah,
Yeah.
I've always had really severe well, hormonal migraines, we'll call them. They were almost all the time, but they were way worse around fluctuations of my hormones, right? So prior to the period, a couple days, and then the first week of the period. And that, I'd have a little bit of reprieve in the middle of the cycle, and that was about it. And I researched it and researched probably over a decade. I looked at everything there was, and it was, so many practitioners think it's too much estrogen. and it's not enough progesterone. That was always what it was, right? And then when you started digging, then it was like, actually, I think it was the fluctuation of the histamine and the histamine intolerance that could be driving it, and then the glutamate piece as well, because that's a trigger
And
for it. It was
potentially even
like a
nitric
big
oxide.
puzzle.
Like if you're fluctuating and
Yeah.
dropping, and then you don't have that estrogen to support nitric oxide and blood flow to the brain, that's another trigger for migraines often. And it's an antioxidant in the brain just on its own, nitric oxide.
Well, it's a vasodilator, so maybe it's could also be the opposite, right? Because like for me, if anything dilated my blood vessels, it would trigger a migraine.
Yeah, that
I
can
needed
happen
the
too.
constriction.
Yeah, yeah.
So maybe with the
So that
increase in nitric
fluctuations.
oxide or that fluctuation of the nitric oxide expanding the blood vessels could have been the trigger too.
Yeah,
And then also
yeah.
the gonadotropin releasing hormone that really matched up to where my migraines were the worst was when that fluctuated. And I thought, that's no one's talking about that.
Right. Yeah. No.
Yeah, yeah, it's a big puzzle for sure. But I think it's yeah, that all of those things have something to do with possible like migraines around menstrual cycles.
Yeah. Multiple factors.
Multiple
It's
factors.
complex.
Yes, very complex. Okay, so let's go into we see now the interaction between these hormones and our brain. So this is like a lot of that what we talked about too was phase one, like detoxification. You talked about the 16 hydroxylation. What about 4 hydroxylation? Does that because you said 16 will not go into methylation, does 4 hydroxylation then need to be methylated?
So you have three metabolites of estrogen. You
Yes.
have 2-hydroxy, 4-hydroxy, and 16-hydroxy. Colloquially, we like to call them the good, the bad, and the ugly, right? So the
Hmm.
good's the 2-hydroxy because it's very stable. The bad would be the 16-hydroxy. I would call it equivocal. It has good and bad traits, but
Yep, that's what I always
can
say.
be.
Yeah,
Yep.
yeah,
And then the 4 is the ugly, right?
yeah.
Because 4-hydroxy E1 and E2. So reverse, 2 and 4 are called catechol estrogens because of where they get hydroxylated through the CYP activity. So you have CYP1A1, it's taking estrogen and estradiol into the 2-hydroxy E1 and E2 forms, and that's putting it on a catechol carbon, or that it's putting it on the hydroxyl group on a carbon that's making it a little more stable and more readily methylated, more akin to wanting to accept methyl groups for phase 2 clearance. What can be dangerous about catechol estrogens, though, and this is more true for 4-hydroxy, where the hydroxyl group is added, and this is through the CYP1B1 pathway. I think 1B is in bad, one, so bad pathway, is that it becomes more unstable. That hydroxyl group is readily taken into a quinone pathway instead of a methyl pathway, and this is part of phase 2. Quinones are more reactive. They can actually, they form, so what 4-hydroxy does is it can form a 3,4 estrone quinone. And these quinones enter into the nucleus and create adducts on DNA, like little speed bumps. So every time that DNA now replicates, that cell replicates, it's going to get a little stutter, right? And 4-hydroxy specifically makes kind of what they call unstable adducts. So that leads to greater risk for that DNA, for that cell to become damaged and to dysregulate replication. And that's kind of the hallmark behind cancer.
Mhm.
So 4-hydroxy increases concern, it doesn't mean it's going to, but concern for cancer if it is becoming a quinone. Now, our bodies have a lot of ways to safeguard against that, right? So 4-hydroxy, if it gets methylated really quickly, not a problem because we know it's getting, I like to think of phase 1 as kind of sweeping up estrogen into little piles. Like the 2-hydroxy is kind of like your recycling pile. You can build up recycling, for a while before it becomes an eyesore, right? It's not going to be really dangerous or stinky or, attract flies or anything. 4-hydroxy is like your compost. It's like, you have a little compost bin for a reason. You want to be taking that out every day. Otherwise, it gets moldy and stinky and flies just accumulate and it's a disaster. It gets slimy. Ugh. So we don't want that to build up, right? Well, the phase 2 of that is taking those piles and putting them into garbage bags. So if you can take and methylate that compost, pile pretty quickly, if you're putting it into garbage bags really readily, not a problem. It's going out. It's when it's left to become stinky for too long that it becomes damaging to DNA. So you want to be really careful. You want to look at that methyl response to ensure you're processing out that 4-hydroxy safely. 16-hydroxy, I think more like garbage, like general refuse. Yeah, it's like a pile where you're going to potentially run into problems if you let it build up too much, but you don't have to take out your garbage every day. You can take it out every other day, right? Like it can build up a little before it becomes really problematic. But again, its garbage bags are very different. It's sulfated
Mhm.
versus methylated. So we have these methyl garbage bags and we have these sulfur-based garbage bags. And they're going to clear out our estrogens. Phase 3 is taking those garbage bags to the dump, quite literally. It's going into the stool, it's getting final conjugation with bile and excreted out either into urine or into poop.
Yep,
And
yep,
that's where I call like the beta glucuronidase, right? The estrobolome is like the little rats that can come
yep.
in and chew open those garbage bags and let that
And
estrogen
then
right back into
recirculate.
circulation. Mhm.
Right. Yeah. So that's where the gut health piece comes in to
Yeah.
that. And then the glutathione, it can also go, can't it go methylation or down through glutathione
So glutathione is going to be
pathways?
your quinones.
Yeah.
Yep. So once they
Okay.
form quinones, the way we reduce those into water and safely get them out of the body is through glutathione reduction.
Okay.
Yep.
Okay.
So we also have NQO1, which is an enzyme that's NADPH quinone reductase. So it's going to be in the cell, the phospholipid bilayer of every cell. It's kind of like a sentry, like a little knight that's guarding the cells. And when it's called to action, it actually upregulates P53, which is a tumor necrosis just response. It's a cell regulator to make sure that if we damage too much from this quinone that's present, that we just go into autophagy, that we turn off the cell and start again, right? So that it can't become cancer, right? It can't become damaged beyond repair. The other thing it's doing though is it's also turning on CoQ10 conversion into active, CoQ10 ubiquinol, and it's activating vitamin E, a potent antioxidant and free radical scavenger, while also increasing NERV2, which is increasing that catalase, which is activating or protecting DNA, kind of cleaning up those adducts, right? SOD, which is superoxide dismutase, goes out and kind of
Hmm.
eats it. I think of it as like Pac-Man. It's like eating up all the free radicals, all these unbound oxygens and nitrogens. And then it's also upregulating glutathione, which is our master antioxidant to package up and eliminate all those quinones. So we have safety guards against it,
Yeah.
but we have to make
That's
sure they're all working well and that we have the right nutrients to support it.
yes, and I'm going to get that's where I was going to go next, but I just want to quickly ask you that P53 enzyme. So on day 12 of a woman's cycle, we have a surge of estradiol, and it's the estrogen peak. And my understanding of it in the beginning, when I was reading about it, was that that peak basically turned on this P53 enzyme, like it helped upregulate it. But that was, and then I started researching it more, and I realized that no, it actually it's like a rebound effect on it, like that it suppresses and then it bounces back up once the estrogen falls. Is that
Once it
do I
metabolizes.
got that right?
Yeah, well, I think, when estrogen's rising, we want all cells to kind of be called to action. We want replication to be at its peak, and we don't want that to be stymied in any way. So P53 being that it's like turns off cell replication so that we can't, would make sense that as estrogen surges. Well, if we ovulate and we get pregnant, we want to be able to propagate cell replication. We're
Okay.
going to suppress. But as soon as estrogen starts to break down and forms quinones, because it always 2-hydroxy is a quinone as well. Now it's stimulating that response to say, oh, we need to turn this back on. We're already breaking this down. We've got these metabolites to deal with. Let's turn P53 back up. So that would
Yeah,
make
yeah.
absolute sense. That
Just get there's so much chatter about should we cycle our HRT. And I
Mhm.
did a whole episode on this and there's not enough research on it. There's almost no research on it. So all you can do is really look at why does the body do what it does in a 28-day cycle? And you
Exactly.
see the purpose behind it, that it's not all about having a period and growing the uterine lining and getting pregnant, that there's other mechanisms at work here, one of them being this P53. So there's just chatter about, or theories that maybe we triple our estradiol HRT one day a month,
Mhm.
just to see if we can get this rebound effect or get that P53 enzyme to maybe upregulate and kick in this tumor suppression that it can do.
I think just as there's not enough research on cycling hormones, there's really not a lot on continuous dosing of hormones
No, there
either,
isn't.
right? Like, and it's
No.
not a natural phase. Our body's not meant to have a steady state of estrogen and progesterone all month long. We're meant to have
No.
fluctuations for sure. And again, as you said, it's like the different responses, not just at a cellular level, but also to the brain, right? And to feedback in the bone and to the liver, right? Like, I think there
Yes.
are benefits to all tissues when we have those cycles. We don't want, because the body gets used to things when it's steady state. It's kind of like exercise, right? Like, you start to stall with your gains if all you do is the same routine day in, day out. You have to kind of mix it up to start, breaking those plateaus because the body gets used to something. When it gets used to something, it gets efficient at it. When it's efficient, it becomes really good at limiting unnecessary spending, so to speak, right?
Yeah.
And so it doesn't clean up as much. It gets kind of lazy, for lack of another way to say, because it's like, oh, we don't have to worry about like changes and adaptation because we're always going to have steady state. We don't, so we can turn off some of these other genes and we can like decrease our nutrient utilization here and just kind of get more, uh, again, hibernated, like more
Yeah.
into
Yeah.
this, where, when you do kind of mix it up a little, the body doesn't get used to that. It's like, oh, we're always going to keep active. We're always going to make sure that we have the right things ready, the right antioxidant response, the right cellular response to these things, the right growth factors, the right, so it's always kind of keeping it on its toes, which we kind of want when it comes to like longevity and anti-aging and,
hmm So, in
not just
your
being
opinion,
stagnant.
like your professional opinion, would you lean more towards cycling your hormones
I
with
do.
HRT? Yeah, and
Yeah,
cycling
I
the
find
progesterone, like so that we take a break from
yeah,
it because it can
absolutely.
suppress it suppresses the estrogen
Yes, it does. It has,
on the
again,
receptors, like
it
on
can
it
cause
acts on
other
the
like negative
receptors,
feedback
right?
response over
Yeah,
time, right? Because it is increasing glucose demand in the brain. We don't want that all the time. We need,
yeah.
it can, yeah, I always think about like when progesterone is at its highest, what's happening in the body? And when
hmm
progesterone is at its highest, that's when we're pregnant. And that's when, right, like acid reflux because it causes ligamentous laxity. One of its roles is it helps things stretch and open up so that we can like start to expand our bodies to make room for a developing baby, right? And in
hmm
doing so, it's non-discriminant. It's going to make everything lax. So we also get that acid reflux because the lower esophageal sphincter is starting to open up a little more. Our SI joints are
hmm
getting more lax. We get low back pain. Our occipital, those tiny little tendons and ligaments that are holding our head up, on our neck, they get a little more lax. And so we can get more like neck pain and headaches and those tension, pains. So there's like, and then it's also it can cause weepiness. It can cause more like edematous swelling, and
hmm
part of that is, just trying to like make more lax the tissues so that we can start to stretch. But it creates more of that lymphatic swell. And so you can see like fibrocystic breast pain with high estrogen because of the tissue growth, but you can see swelling in the breast that causes discomfort with too much progesterone because it's just swelling,
Yeah.
right?
And
You can
once
get like
again,
the
everyone blames
peripheral.
estrogen for breast
Exactly.
soreness, and it's
I know. And
like,
it's like, well, sometimes it's
hey,
progesterone.
it could be your progesterone because it's allowing more water to get in there, like water retention.
Yeah, so it is a balance, right? It's always about the balance because
Yeah.
there are good and bad to all hormones.
hmm
Right. And
hmm
we don't want them in excess ever. We want, like, why would the body surge it? Well, it surges it for a specific purpose, and then it's back down to a regular balance, And so it's like, and this is the other thing that always gets me, it always cracks me, like makes me ponder, I guess, is
Yeah.
that when a woman is like prone to frequent early trimester miscarriages, the responses give them 200 milligrams of progesterone. And that does help, right? It helps maintain the pregnancy until the placenta can fully form. And then the placenta is making so much progesterone, like it just takes over from there, right? Like you could never give enough to match placental progesterone synthesis. But to get to that point, you're giving 200 milligrams. The typical dose to a postmenopausal woman is 1 to 200 milligrams. So I'm like, why are we giving the same amount of progesterone to a pregnant woman to support her first trimester of pregnancy as we're giving to a postmenopausal woman? Like, anyway, that's just
I know, but then
something I've always pondered. And then we
when
give
they
it like
take
every
it,
day, forever.
yes,
It's
I
not just for 3 months.
know. I
Right?
know. It drives me
Anyway.
nuts. Yep. And it's funny because I think that when women hear this, when they hear me talk about it, you talk about it, about the importance of cycling progesterone, it resonates with them. like I can't tell you how many women have reached out to me after I go do a podcast about this, where I talk about cycling, where they go, I want to do this. I've been on static dose, but I want to try cycling. And it's like, yeah, there's something about it that just makes sense. And I always think like if we can, like there's not enough research on it. So if we can, should we not try to mimic Mother Nature as close as possible? We never will. Like there's the Wiley protocol and physiologic restoration where they're really trying their best to mimic levels of hormones through a 28-day cycle. But could we, do something a little bit more simple that we could still, feed into this? Like, okay, well, let's peak it on certain days. Let's cycle the progesterone and maybe we'll get a better reaction long term, especially. And that's what I see when people say, well, I feel fine on static dosing. And it's like, great. Okay. Then don't change anything. But if you suddenly don't feel as well as you used to, could that be why? And maybe then that's your like, maybe I should try cycling and see if I feel better.
Absolutely. And I do think even if you're steady state dosing, having little hormone holidays where you do come off of them just for a couple of days per month or every few months, just to give your body that letdown, because the body never has, again, as we were saying before, you never have this much like continuous state hormone all the time. It's always in flux a little, and it does go pretty low when you're on your menstrual period. And I think having that letdown also just helps the receptors reset and helps the body respond to it more and just correctly like adapt to the right feedback response. So even just like a
Hmm.
little supplement or a little BHRT holiday can
Hmm.
be helpful. Uh,
Do you
yes.
you did so much with Dutch testing, and you still do. And we're going to talk about endo access. Uh, did you find with your patients and just with working with people that their genetics, their DNA report matched up with what their Dutch said, or are there so many other factors that are going to influence how we metabolize our hormones? Or do genetics really kind of trump all of those? Like it's just like that's really telling you what your genetics are doing when you look at a Dutch test.
Well, they do match very closely, I would say.
Yeah,
Yeah,
I find that they
absolutely.
do. So,
Yes.
yeah.
And what I think though, what I use their genetic report for is really as a decoder ring to understand the phenotypic expression, to understand what the metabolites on the actual Dutch are telling us, because that's what we're going to treat no matter what, right? But it's like, okay, how do we treat it? And that's what our genes tell us. Because if you have someone who's a poor methylator, for example, methylation of our catechol estrogens 2 and 4, dependent on catecholamine O-methyltransferase, as its name implies. If you have a MET-MET variant on that enzyme in a region associated without folds, right? Because these are all single nucleotide polymorphisms. They're just one little change. We're not doing full gene sequencing, right? This isn't like disease genetics. It's functional alteration to activity, basically, right? Is what our SNPs are. But they're impacted by nutrition, by lifestyle, by environment. And knowing what their risk is can tell us how sensitive they are to those factors, right? So, like with the COMT, we know that the MET-MET variant at this key location, so that one base pair has altered an amino acid that forms in this very long chain of amino acids that are ultimately linked to make a protein that is the COMT enzyme. Changing that from a valine to a methionine is what's happened, right, with the variant. And methionine is very bulky as an amino acid, so it actually makes the enzyme really slow. It's like
Mm.
it's bigger. It takes a little longer to get SAMI and take it to the catechals and donate it, and so you can see a slower rate of conversion of the catechol estrogens into their methoxy form, right? So their garbage bags aren't getting produced as quickly, which
Okay.
means that the piles can build up.
Yeah.
Now, if I saw that and I know someone's a MET-MET variant, that they have the dual methionine, one copy from each parent, right? Then they're totally slow. They're going to be, I don't ever expect that to get high. They're never going to be fast methylators. What I do expect though is that 4-hydroxy gets lower. We need to make sure 4-hydroxy does not get too high, that their glutathione production is really good. So we may need to look at other genes like GSTs,
Hmm.
GSTMs, GSTP, like all the glutathione synthesis. GPX is another one. And then NQO1 you can look at as well. And I like to know that variable because it's so strongly linked with increased risk for oxidative damage if 4-hydroxy gets high. And if they're poor methylators, that's a risk. But the other thing is knowing what pushes 4-hydroxy. Well, 4-hydroxy goes up, that CYP1B1 expression goes up with polyaromatic hydrocarbons. We know that there's two variants, two genetic SNPs. One is in the CYP1B1 expression that actually slows down activity. So you actually don't convert as quickly into 4-hydroxy. However, what's interesting about that variant is although it has lower risk for uh, breast cancer, endometrial cancers, ovarian, like hormone dependent cancers that are driven by 4-hydroxy, it has a higher risk of never smokers getting lung cancer. And the reason being,
Oh,
right, because although, right, there's always two sides to the story.
yep, yep.
CYP1B1, not only does it convert estrogen, estrone, and estradiol into the 4-hydroxy forms, it's also converting polyaromatic hydrocarbons into more inert or less active forms, right? If it's not doing that, you build up these intermediates, these peroxynitrites that are very damaging to cells, and that can actually increase risk, specifically in the tissues that are going to be inhaling those polyaromatic hydrocarbons, which is basically anything lit on fire and inhaled.
Oh,
Right? So all of our petroleum smoke and pollution, right, is going to be inhaled, and that can actually increase risk for cancer if you have this variant. You may not
oh.
have the estrogen-driven cancers, but you may have more of these environmental risks, right? And so it's very fascinating to see that. But
Hmm.
knowing that too tells us increased exposure to just a normal variant of CYP1B1, increased exposure to polyaromatic hydrocarbons are going to push 4-hydroxy as well because you've increased expression to deal with the polyaromatic hydrocarbons. So now that
Oh,
enzyme's just overexpressed, your estrogen is going to pull right through that path as well. So reducing, if you have someone who's a slow methylator, we support them. I want to see it move a little, but it's not going to ever get good. But
okay.
I know then that I really have to protect their oxidative stress. I have to or protect them against oxidative stress and reduce those things that are pushing for hydroxy specifically. So reduce the polyaromatic hydrocarbons, which are your smoked meats, your smoked anything, cigarettes, anything like if you're doing recreational marijuana, lighting anything on fire and inhaling it, right, is not, it's going to increase expression. But also how close do you live to a major thoroughfare? Are you living in a polluted city? Do we need to make sure that you
Forest
have,
fires?
yeah, forest fires for sure.
Ooh,
Yes,
yes.
absolutely. That's a big one.
Okay. Okay.
And so making sure if that's the case for them, that they stay indoors during those seasons, right? Reduce their exposures as much as possible, have good air filters in their home,
Yeah.
and really increase glutathione because that's going to be their route for detox and making sure that NQO1 is working optimally. That's CoQ10, vitamin E, having
Yeah.
sulforaphane, which is kind of from our broccoli sprouts,
Yeah.
great nerve 2 promoter. But pomegranate green tea, like all these great antioxidants, right? Vitamin C.
Yeah. 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 Because
But
I have like two, like I was read it out on oxidation. Like I have a major problem with that. That's probably the worst snips, some of the worst I had out of all the hormone ones. So with because of that, then is that what could increase my 4-hydroxylation
yep,
levels?
absolutely.
Oh,
Yeah.
okay. I did not know. I mean, a lot of this is over my head. I don't mind telling you, but but I'm
Well,
trying to
this
put it
is,
together. The genetic
yeah.
thing, I get very confused about. I always tell people I'm not a genetic expert, so don't come at me with your genetics. I can read your Dutch and I can be like somewhat see the genes and but I always say go see a genetic specialist that, to get to understand your genetic report, not me.
Well, not even, it's not a genetic specialist. I always like to differentiate that. A genetics, like a geneticist is looking at gene and
Right.
disease correlation. And so they're looking at preconception. And you really want a nutritional focused genomic expert, like someone who's looking at your genes through that functional lens. But
The
I
epigenetic
digress.
side. Yeah.
Yeah.
Yeah. Yeah. Yeah.
But again, like you always treat what you see, right? Because if you had someone, let's say you had a wild type COMT and they had really slow methylation, well, you still need to treat their methylation, even though it's likely not a COMT issue. They're probably their enzymes working pretty well. They may not make enough SAMe, so then you have to look upstream. How well are they actually forming, taking all of their methyl cycle into its final product, SAMe? Be a whole host of issues throughout that whole cycle. Does start kind of with the folate side. So I always, tip my hat to MTHFR, but that's not where you want to focus. Like it's just one of many,
I know, and everybody
that blood
focuses
thinner.
on that.
Everyone does. It's like the gateway snip.
Yes,
But
yeah, the gateway snip, totally.
but it goes beyond that, right? But you need to make sure they're making SAMe, but also not suppressing COMT. And so things that are going to suppress COMT activity, even if they have the valine variant, so they should be pretty speedy in their activity and making tons of garbage bags all the time. Well, if they're not, are they drinking too much coffee? Because that's a catecholamine as well, and that's going to totally deplete all their garbage bags, right? Like, so what is their coffee consumption? Do they have enough magnesium? That's a cofactor for COMT activity. If they don't have enough magnesium, they're not going to be making garbage bags, right? Even if they have totally good function.
Right.
B6 is another intermediate.
Yep.
And then there's even like folate independent CME synthesis, which is through BHMT, which is your homocysteine methionine transferase. That one's B6 magnesium dependent as well. So you're kind of supporting both by doing those nutrients, as well as glycine, trimethylglycine. See that methyl group, right? Like, so it's like, and so those can be really nice ways to support, knowing that
Yeah.
they probably, once they clean up their environment, if they're under a
Yes.
high amount of stress, that's dopamine, norepinephrine, adrenaline, epinephrine, also catechol. So we want to reduce stress. We want to support their adrenal health. Lead is a direct inhibitor of COMT. Are they exposed to lead? Do we need to worry about that? Right. So you can start looking at like, okay, they should be functioning well here. Why aren't they?
Why
And now,
aren't
so
they?
you can see how the
Oh,
genes and the
yeah.
results can really start to impact how you further evaluate the patient. Yeah.
Oh my gosh, there's so many more pieces to the puzzle than people think there is. I mean,
Yes.
people ask, oh, why should I do a Dutch? I wonder. Right? Like, oh, might just be able to tell you some things. Your genetic
Yeah, and that's
report, a Dutch report, like I think those are two of the most important things for women to do.
absolutely. And the genes are one and done. You do your report, your genes don't
Exactly.
change. Their
Yeah.
function changes, but and the expression changes. That's why you want to track it with tests like the Dutch that are looking at
Yeah.
expression,
Yeah.
at intracellular expression, right? It goes so much more beyond just the hormones themselves.
And this just proves that, we're taking so much of the guesswork out when we do tests like this, right? You can
Yeah.
spend how much money trying to figure out which pathways need supporting, right? If you're having problems with HRT, if you're having just natural issues with your hormones and their fluctuations in your 28-day cycle, well,
Yeah.
it's not as easy as let's just slap in some dim and call it a day. Like there's so many more pieces to this than people realize.
Well, and so many, it's like, oh, we need to detox estrogen. Let's say you just did a blood test or you just did a salivary test, and estrogens were high on a single point at a single day in time. That's my other caveat. It's like a single point in a single
Right?
day. Whereas urine, yeah, it's a single day, but it's over the course of the entire day that you're capturing that cellular response. But that aside, uh, like say you had a single point of estrogen elevation and they match the symptoms. They're having very heavy and painful periods. They're having a lot of breast tenderness, headaches, mood changes. And then you give them DIM and they feel so much worse because you didn't look at their metabolites and find out that they actually are really poor methylators. They don't make a lot of estrogen. And now you just pushed them heavily into the 2-hydroxy, but they had no garbage bags, right? You just
Right. So now we're
put a
just
bunch of,
piling up the garbage.
yeah, you're just piling up a pile without any way to get it out. And then they feel worse.
Yeah.
Now I'm one of those
Yeah.
people, like, don't give me DIM.
Same. Yeah, no, I cannot tolerate dim. I have a real problem with dim. I've talked to you about
Yeah.
this before because it's over recommended.
It's over recommended. And it's not, you have to be careful with the form of DIM you choose. Not all DIM is created equal.
Yeah.
And I think when you look at a product and you're like, oh, it has DIM, great. Maybe you do need it. Maybe you do benefit from it. You're not going to benefit from all DIM, right? You really need a lipo,
I was
like
gonna say
soluble
that. Yeah.
form.
Yeah.
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 So
Be
it's,
very
yeah, because
careful.
it
Yeah.
oxidizes. It's an antioxidant. It's going to
There we
oxidize really
go.
quickly
There we go.
and
And
denature.
so
Mhm.
let's talk about endo access. I mean, I can sit here and pick your brain for another, 10 hours here, Liz, but I'll try and respect your time.
No, no.
I was thinking in my head, like, I think I just got to pay this woman just to sit and consult with me. And so because I can learn so much from you. Um, Endo access. So just a little backstory here for everybody. I was at a conference at Health Optimization Summit in Austin a couple months ago, or a month ago now, and I met your business partner. And I saw him do a big talk about gut health, and I went up to him and started chatting with him, and I said, I want you on my podcast. And, and then he was like, once he realized that I was in the hormone space, he was like, oh my gosh, I have this new software system called EndoAccess where you can put in you can upload your Dutch tests, and it's going to give you this really comprehensive report, as well as we've created our own line of hormone-based supplementation. I was so excited. And then he's like, actually, you just need to talk to my business partner, Liz. He's like, she's a hormone whiz. And so this is how this all came about, right? He introduced us and he is going to come on the show, but I wanted to get you on right away to talk about all of these things that are hormone related. And now, since then, I have now started using your line of supplements, which is the only line of hormonal supplements that is like this. I've never seen anything like your guys' products before. They're super comprehensive. You not only did you have your touch on these supplements, so did Carrie Jones, who is also very well known in the hormone space. She's brilliant and has been in the Dutch space as well, the urine metabolite testing space for a long time. And then Kiran, am I saying that
Mhm.
right? Kiran,
Yeah, correct.
your
Yeah.
business partner. I mean, he's brilliant like just absolutely brilliant. He's like, what is he, a biochemist or something? What was
He's a
he?
microbiologist. Yeah.
Microbiologist. I knew it was something like
Yeah.
that. Yeah, microbiologist, super smart,
Yeah.
like amazing. And so you guys have kind of come together and created this very unique line of supplementation.
That, and it really did stem out of our time at Dutch, and just hearing the concerns of providers over and over and piecing it all together, knowing which enzymes are involved with which hormones, with which dysfunctions, how we want to really like optimally support them and finding like okay, there's really no product on the market that has all of it together.
Mhm.
Like you can pick and pull and put lots of things, lots of different products together and hope to cover your bases. But you're likely missing a few things. You're maybe not in therapeutic doses for everything. You're getting excess, on other things that you didn't necessarily need, but it was the one product that had that one, ingredient you were looking for. So it was spurred out of this desire to have something that was more comprehensive, that
Yeah.
did treat, I always say it treats the why, not the what, right? So it's
Yes.
instead of a symptom, instead of saying, oh, you're estrogen dominant, saying, no, we're going to give you a product that's treating why you feel estrogen dominant based
Mhm.
on your metabolic patterns.
Yes.
Right? And again, like you said, I always like to use our detox line because we have five primary estrogen detox blends. We don't just have one, right? Like some
It's not
products,
just
like
dim, everyone.
just dim or a kitchen sink of like everything, where
Yeah.
it's we have products that are working really just maybe you do need DIM. Well, then we're going to give you bioresponse DIM, that phospholipid bilayer DIM. So it's really, or phospholipid bound DIM. So it's really more stable. It's getting into the tissues. It's actually getting utilized. It's not just oxidizing and getting peed out as expensive urine, right? Like what's actually going to do
Mhm.
is chill. And it's more shelf stable. So it's not going to sit in a capsule for months on end and then denature and not have effect once you take it. It's actually going to still benefit at any time, right? If you needed it. Now, we also have just a methyl product. And it's not just, I don't want to say it's just methylation. It's actually supporting COMT, not methyl cycle. It does support SAMe synthesis, but it's not going to push you into like, if you had for example, a folate sensitivity or methylfolate sensitivity, you're not going to get that drive or that excess kind of like folate or methyl trapping that can happen because it's really supporting SAMe synthesis, COMT activity, magnesium, B6, right? Trimethylglycine,
Mhm.
serine, which is also very neurocalming.
Mhm.
um,
Yes.
but it's also helping on the sulfation side. So we have a little taurine and choline in there as well, because we know if you're supporting one of our phase two detox pathways, we really need to support the other primary biliary conjugation path as well. So it's not just like giving oh, you need methyl support, here's your methyl product that's just supercharged with methyl B12 and methyl folate and, and then, oh, well, you're missing, trimethylglycine and you're missing taurine and now you're missing, now we have to give you all these other products. Well, here you just have the methyl sulfur, like phase two deluxe package, right? Like for
Yeah.
estrogen, because that's sometimes all people need. Or maybe they just need their gut. Maybe it's just their estrobolome. And on the Dutch test, you can see patterns that kind of speak to whether sulfation and estrobolome response is a problem. If you're seeing higher estrone, higher 16-OH, higher methoxy, you're starting to see a picture, right, of, oh, this could definitely be a GI issue. And then you give more of the biliary support. You really help calcium deglucarate, right? You're
Hmm.
helping reduce that beta glucuronidase activity if needed, but not
Oh my
everyone needs
gosh.
it.
Yeah.
And here's the other kicker: calcium deglucarate for therapeutic potential really should be about a gram a day. You can get
Yes.
away with
Yep.
500 if it's like low estrogen picture, but you need about a gram. Most
Yep.
detox blends have calcium deglucarate at 100 milligrams. And it's
Oh
like,
yeah.
okay,
Yep.
so you're going to be adding that
Exactly.
in too.
Hmm. Hmm.
So it's
I
like
find
an
that.
homage
Yep.
to say, like, oh, yeah, we have it, but it's not really a therapeutic dose. So we also make sure that all of our products, not only are they what you need, where you need it, but they're in the therapeutic doses that you need to.
And you've combined them synergistically with their cofactors and things that they need to work properly. You know, you were talking about before we started airing, like that magnesium, for instance, is in smaller doses, and some people would maybe say, well, this isn't enough magnesium to meet my, recommended daily amount. But if you put too much of it in, it's a too big of a molecule, I think you had said.
Yeah, it can block
Yeah, it can
receptor
block
response. So
receptors.
you can't
Yeah.
get like absorption of all your other cofactors and minerals that you
Yeah.
need, or even some herbs can get blocked, So you don't
Yeah.
want big doses of magnesium or calcium for that matter. Even potassium's on the bigger end in a formula that has other things going on. Now, if it's just a mineral blend, I always say just take your minerals, like the bigger, bulky minerals at night. Like take them on their own in a
Mhm.
powdered form, maximized dose in the evenings when they're
Which
going to
is a
be
good time to
utilized.
take magnesium.
Yeah,
Helps
exactly.
with
Sometimes
sleep.
it's very calming.
Yeah. Yeah.
And then we just give the little hormesis, the little like cofactor dosing, like
Yeah.
act as a co-pilot to make sure that the enzymes have what they need to function well, but aren't bombarded.
Hmm.
Still will absorb everything else at the maximal levels.
Hmm. So as of right now, the line of supplements is only available to practitioners, correct? It's not
Correct.
available to the public. Yep.
Yeah, if you have a full script, if you have a
Yeah.
provider who gives you access to their full script catalog, you could see our products through that. But yes, it's only going to be through full script right now. Yeah.
Yes. And so I have started recommending these because I do have a full script account. So we have started using them, but we eventually will start carrying them in our shop, I'm hoping, because you guys are looking at doing them wholesale to practitioners. And it just made like I've always thought, oh, I need to do my own line of supplements for hormones, but it was such an undertaking that I just am like, oh, I can't yet, And I just kept going around like, well, I want a supplement that has all of this in it, and I want this supplement, I want that supplement, and then I meet you guys, and I'm like, they've done it. I don't have to let you guys do it. As long as I can carry the supplements, I'm happy. So keep on the lookout in the shop, listeners, because I will eventually hopefully have these in my shop. Right now, you can get them if you purchase a Dutch test through me. I am using Endo Access, so I am doing the reports through there as well as my own interpretation. And then I am recommending what supplements are going to help you with your unique Dutch profile, your metabolite profile, which is so cool and so amazing. It's just taking it to the next level.
That's our hope. Yeah, so the Dutch test is so complex,
It
and I think it
is.
can often get lumped in with general sex hormone analysis, which is just to look at absolute values. Endoaxis goes beyond that. It's saying, here's their
Yeah.
values, but here's how they relate to the enzymes that are breaking them down or responsible for their synthesis, both up and downstream, and what could be causing an imbalance to why that hormone might be at the level it is, even if it's in normal range. Is
Yeah.
it? Is it really functioning at a normal range? We don't know. And if those metabolites are telling us a different story, that's going to reveal something at a cellular level that could be driving symptoms that would otherwise be missed if all you looked at were just absolute values.
Yeah.
So it's
Amazing. Oh my
yeah,
gosh.
very
And
exciting.
I'm going to just do a coupon for everybody that's listening to this that made it all the way to the end of this very deep dive into hormones or way over time now. If you've made it to the end and you are interested in purchasing a Dutch test, you can get $20 off your Dutch test with coupon code we'll go Liz 20 because then I'll know that it's people that listen to the podcast that are using the coupon. And I'll put it in the show notes. So if you forget, it'll be in there, everyone. And then I'll make recommendations on what products because they're so like it's complicated. You can't have them go out to the public. They're just too like
Exactly.
there's what they all consist of and how you match them up to people's hormonal profiles. It's way beyond what the normal person could do for themselves.
And that's why we numbered them as well. You'll see them
Yes.
numbered, not named. And part of that was, A, how do you name something that's treating a whole enzyme
So
cascade?
right, right.
But also to really help ensure that there's not a bias towards a name or a title, that you're getting what was
Yeah.
recommended based on values assessed through this algorithmic calculation. And it could be that, for one person, they might need two different titled things that totally contradict each other. And yet those nutrients are so critical and so key that they actually don't contradict, right? In terms of the
Mhm.
formulas themselves, if that makes sense. Whereas the numbers, you just know, hey, I got number one and number four. And I know that those two are going to work synergistically based on what I had.
Yes.
So anyway, yes, that's why
Oh,
it's here.
Liz, you are the best. This is probably one of my favorite interviews I've ever done, honestly, because I'm
Oh,
learning so much from you. And like I said before, it doesn't happen very often. I don't want to toot my own horn, but I know a lot about hormones. So to find someone that's like so much, so much more than I do, it's just fascinating for me. And I love to learn. So thank you so much. Out of 400, and we're at 410 episodes. So that says a lot.
wow, thank you. I appreciate that so much.
Well, I appreciate you. So thank you very much for your time today. And I appreciate it. And I hope to have you back multiple times.
Absolutely. Oh, I would love it. Absolutely. Thank you so much, Karen. This has been such a pleasure.